You know, vasectomy is such a simple procedure. It's why it's the most popular method of birth control, really, in most countries. And it's just a simple matter, as you might recall, in the doctor's office, under local anesthesia, maybe a little sedation, making a little tiny puncture-size almost incision in the scrotum, very small incision, and then cutting that duct. And that's the duct that carries the sperm from the testicle up into the abdomen and back around into the ejaculatory duct. So it would seem like the way to solve the problem in reverse of vasectomy would be simply to reconnect the two ends of the vas. That is, where it's been cut and where scar tissue is filled in, just to reconnect the two ends. Well, that's not so easy to do because the inner canal of the vas is extremely tiny. It's almost the size of a period at the end of the page, even though the outer wall, the thick outer wall that makes vasectomy so easy is very easily discernible. It's a tough muscle that can be palpated under the scrotal skin, and that's why it's so easy to do a vasectomy through a tiny incision, because that thick outer wall of the vas is very, very tough and hard. But to reconnect the inner canal is somewhat more difficult because the inner canal, where the sperm is transporting through, is very, very tiny. Nonetheless, you can imagine that if it were simply a matter of the vas being blocked, it should not involve anything more than microsurgical technique and relatively short order to reconnect the vas. The problem is that most situations, the vas deferens being blocked has caused a pressure buildup going all the way back to the more delicate duct, which we call the epididymis. The duct that conveys sperm out of the testicle into the vas is a 20-foot long, extremely thin, very, very, very fragile microscopic duct called the epididymis. It's 20 feet that's been accordioned, squinched into a space of about an inch or an inch and a half, and it's like one long, extremely flimsy, microscopic wet noodle, and all crunched together in this sausage-like compartment called the epididymis, and then that leads into the vas deferens. Now, if it were simply a matter of putting the vas together, it would require some microsurgical technique, but the procedure could be done relatively simply and a moderate chance of success as long as the vas was reconnected properly. The problem is that in over 75% of cases, the blockage in the vas causes pressure buildup all the way back to this epididymis and right to the testes. This pressure buildup, demonstrated here, results in blockages and blowouts somewhere along the epididymal tubule. Secondary blockages caused either by concretion of this retained blocked material or actual perforations and blowouts in that very delicate epididymal duct, which results in secondary blockage. So it's not just a matter of reconnecting the vas, that is, putting this side of the vas to this side of the vas, but it's a matter of bypassing the very complicated blockages in the epididymis over 75% of the time. So if one were just to simply do a vas-to-vas reconnection, say under local anesthesia as an outpatient, the chance of success, no matter what anybody might propose, really couldn't possibly be more than 25%, and that would be assuming they do a perfect microscopic reconstruction. So I have here just to discuss just a simple case of a patient that wanted to tell their story that would be of some help. This is a gentleman that had a vasectomy 23 years ago, and he went to an outpatient center where they simply did vas-to-vas reconnection under local anesthesia, a little sedation, just as an outpatient, sent him home the same day, and actually sent him back to his hotel the same day, and then he went home. And this gentleman had blockages in the epididymis, that is, in all the way up here in the epididymal duct, which is an extremely delicate area. And so just putting the vas together right here, cutting out the scar and putting the vas together, which is what was performed for him, didn't have any chance whatsoever of a success. There was no motile sperm in the vas fluid, and one could predict, in fact, one could guarantee that no matter how perfectly the vas was reconnected, if it were connected perfectly, the operation would have to be a failure. So he spent $7,000 for nothing. He should have given this surgery center the $7,000 in return for not even touching him, because all that happened is it created a lot of scar tissue that required even a bigger operation to do the vasoepididymostomy, which is what he needed. So he actually came to us just several weeks ago, and we opened the scrotum with a modest incision, and we had a general anesthetic for it. We cut out all the scar from his previous surgery and found out indeed that the reversal site was blocked, but it didn't matter because there was no sperm in the vas fluid anyway, and so he had epididymal blowouts and blockages, and so a vasovasostomy couldn't have possibly worked regardless. So we went ahead and connected the vas to the epididymis, as we routinely do in all cases where we find no sperm in the vas fluid. So since there was no sperm in the vas fluid, what we did was a bypass to the epididymis, in which we made an opening in the epididymal tunic, the outer tunic of the epididymis, found the point in the epididymal tubule where sperm was leaking from that was beyond or proximal to all of his secondary blockages, and then we did a perfect reconnection of the vas to the epididymal tubule, the vas lumen here to the epididymal tubule, which you can see depicted here, where we connect the inner canal of the vas to that very, very thin epididymal tubule, and then the outer muscle of the vas gets connected to the outer tunic of the epididymis. So this procedure, there was good motile sperm. This procedure, for over 95% chance, will result in a normal sperm count. Furthermore, we were able to freeze the sperm which we retrieved. So if he's one of the 5%, or in difficult cases, one of the 10% that fail, we still always have frozen sperm that could be used in the future for getting his wife pregnant with ART procedures. So he never has to have another procedure whatsoever on his scrotum. The problem with the procedure that was done with him the first time, a year and a half ago, and which is typically done in most outpatient settings, the problem is that there was no motile sperm in the vas fluid, no sperm was frozen, there was nothing available in the future for an ART procedure or an IVF procedure if the operation should fail. The operation was guaranteed to fail despite all the money he spent, and $7,000 is a huge amount for such a simple thing that he had done. And yet, despite that outlay, he still doesn't have any frozen sperm available for IVF, and he has the same blockage he originally had, which is in the epididymis. So what we want to point out is that in order to do the reconnection with a high success rate, it's important to check for the sperm in the vas fluid, not just for the fluid, not just to see if there's some sperm parts or debris, but to see if there really is viable sperm, indicating that the entire epididymis is intact. Now, about 20 to maybe 25% of the time, the epididymis will be intact, and all we have to do then is reconnect the vas to the vas. And of course, I say that casually, but of course it has to be done correctly. A proper two-layer reconnection with the flimsy inner canal being sutured with microscopic sutures in the first layer, and then separately the outer layer of muscle to be sutured with somewhat heavier but still microscopic sutures. So it should be done right, but nonetheless that's much simpler. But if there is no sperm in the vas fluid, and 75 to 80% of the time that will be the case, one is really wasting his time having had any incision or any surgery other than the proper vasoepididymostomy, which really must be done under general anesthesia in a proper operating room setup and with the patient able to stay in the hospital overnight. The pain is minimal as long as the procedure is done properly in the hospital, as long as drains are put in and he's seen the next day by the operating physician, in this case me. It's really minimal pain. But it's a major procedure and a big procedure despite minimal pain. It should be done the proper way if you're going to have the highest chance for success.